injection as opposed to a hospital setup where one may have access to ultrasound guidance and so on. Because even if one is attached to a hospital, one may have one's own clinic, and in a clinic it may not be possible to get all the paraphernalia. So this is meant for bedside, as a bedside clinic procedure. And then give a little illustration of the procedures and hands-on on the mannequins, which our 3 faculty will take you through and provide that for you. So what is the utility of local injection therapy? One, in any inflammatory joint disease where the joint inflammation is proving to be difficult to settle, and this could be prototype being rheumatoid arthritis or any other condition, spondyloarthritis, juvenile idiopathic arthritis, in the connective tissue disorders, or distal synovitis. The indication affecting or wants to confirm gout or septic arthritis. So for the inflammatory joint disorders, one can inject either a steroid, methylprednisolone or triamcinolone. One used to at one point in time for very, very resistant single joint inflammation, one would use radioactive substances. Initially it used to be radium, now it's yttrium. And perhaps very occasionally one may still find the need to do that. For osteoarthritis, one can inject steroid, one can inject hyaluronic acid, the viscosupplementation, and there is some role for platelet-rich plasma, which one can use in treating osteoarthritis or for the management of pain in osteoarthritis. Soft tissue lesions, it would be steroid plus minus a local anesthetic. And in synovial fluid analysis, the most important things to look for would be a gram stain, a white count, the culture, and for crystals. So what would be the absolute contraindication to needling a joint or performing a procedure? It would be septic arthritis, either confirmed or suspected. Let's say we put in a needle in a joint and we get turbid, pus-like fluid, then obviously we won't inject it until we can rule out infection. Relative contraindications, there are quite a few. Prosthetic joint, but some orthopedic surgeons, after a joint replacement, if there is persistent inflammation in the joint and they are fairly certain that there isn't any infection, do sometimes inject the joint. But that's something which one might not readily want to do it in a clinic. If there is skin infection in or around the joint, if somebody has uncontrolled diabetes, because a certain amount of the steroid will get absorbed and it can raise the sugar. Again, with psoriasis, for the same reason, if there are lots of lesions around the joint, the risk of introducing infection into the joint increases. By and large, in osteoarthritis, joint injection is not that helpful, except if there is a persistent pain at the first CMC joint or the knee joint. Injecting it can sometimes prove to be very helpful, particularly if there is a certain amount of inflammation due to chondrocalcinosis. And of course, if one was to consider viscosupplementation, then an intraarticular hyaluronic acid can be injected. So what joints can we inject? Well, literally we can inject any joint, and any joint can be injected in the bedside, with now currently one exception being the hip joint, because it's a large joint. There are structures around blood vessels, nerves, and doing a blind injection may not be a good idea, and this should perhaps be done under image guidance. But most of the other joints, knee, shoulder, ankle, wrist, elbow, MCP joints, small joints of the hands, they can all be injected fairly easily as a bedside procedure. One caveat, that one probably shouldn't inject more than 2 large joints at one single sitting, for the simple reason that way the steroid dose becomes rather high, and the patient may get some Addisonian symptoms once they start to move around. Soft tissue lesions, there are plenty around the shoulder, acromioclavicular joint, tennis or golfer's elbow, around the hand, deep veins, trochanteric bursitis, and plantar fasciitis. These are some of the more common ones that I have listed. There are a whole range that can be seen and can be dealt with by a local injection. What drug and dose should one use? The two most widely used drugs are methylprednisolone or triamcinolone. And these are the depot preparations where they tend to last in the joint for some length of time, as opposed to, say, a more soluble preparation like hydrocortisone. For a large joint, one would use 80 milligrams, so knee, shoulder, 80 milligrams for each injection. A slightly smaller joint, 40 milligrams at the elbow or the wrist. Sometimes injecting distends the joint a lot and becomes painful, so at the wrist one might use sometimes only 20 milligrams because then the volume of injection reduces. Ankle 40, and the small joints of the hands 20 or sometimes even 10 milligrams, because injecting the joint becomes painful for the patient. So this method, what we are trying to sort of describe, it's a bedside clinic procedure. Operation theatre or surgical gloves are not required unless one would like to use the surgical gloves for more personal protection. And providing it's a good no-touch technique, which we shall try to describe, and we use good quality disposable pre-sterile equipment. As with any procedure, it would be helpful to explain the procedure before doing the injection, so the patient is aware of what is going to happen. We should keep all our equipment ready and handy, and this is meant to describe a situation where the rheumatologist or the physician is doing the procedure single-handed, without 2 or 3 or 4 people to help, so that it can be done smoothly, efficiently, and fairly rapidly. One should make sure that the positioning of the patient is adequate, and also of the person who's doing the injection, so that you don't run into an awkward situation where you're unable to actually make the injection. One marks the injection site and then aspirate and inject, and then of course what aftercare, if any, is required. So place and equipment, one should decide what one is using, either methylprednisolone or triamcinolone. One should keep 2 ml syringes for the actual drug, 20 ml for aspiration, particularly from a large joint like the knee. 20G is a reasonable size needle to use for aspiration. Some might suggest 18, but then that becomes a little painful when one is actually injecting it. 21G to inject large joints, so this would be yellow, this is green color, and 23 and 24 gauge needles for injecting smaller joints like the wrist or even the MCT or PIP joints. Keep an alcohol wipe or spirit and betadine. Local anesthetic if one is injecting a soft tissue. Some would like to actually add the local anesthetic to the steroid while injecting a joint, but that tends to take away the pain, and the risk is that the patient may actually overuse the joint. So some don't add local anesthetic and just inject the steroid, and something to cover the injection site at the end of the procedure. So what we've looked at so far is that there's an indication for the procedure. We have ensured that there are no contraindications, explained the procedure. There's a tendency to sometimes try and force it on the patient, but if the patient is reluctant, then it's really a good sign to not do it, because something may go wrong or the patient may not actually get benefit. And then we go ahead and see what the procedure is. So depending on the clinic where one is actually working, if one has a smaller clinic, you could have a small area to lay out your stuff, have everything within reach, and these sterile packs are actually very helpful. They're not very expensive. They come with a tray with 2 areas for putting in your spirit and betadine. They come with a cotton swab and gauze, and you can spread out everything, the syringe, medication, betadine, spirit swab and a bandage. If your clinic location is slightly different, you may spread it out on a trolley, and roughly the same thing. Everything is available to hand. Positioning the patient is important. The patient should be comfortable. If one is wanting to inject the knee should be nice and relaxed. Put a clean, not necessarily an OT sterile cloth, but a clean drape underneath. So this is positioning for the wrist. Again, the patient is comfortable, the hand is resting comfortably. Mark the injection site. Supposing this is the point where one wants to put in the needle, and this our faculty will explain when you're actually on the mannequins as to how you locate where you want to inject. Then you can make 4 crosses with the pointing to the center of the spot where you want to inject. You can clean this with spirit, betadine, and then you should be able to make the injection. So the patient has comfortable, there's a clean, sterile cloth underneath, and the injection is being done. Soft tissues, I'll mention 2 which are very commonly seen. Shoulder, rotator cuff lesion, where sometimes it's difficult to separate which tendon is responsible. So a subacromial injection into the subacromial space actually reaches most of these tendons and can be quite helpful. Biceps tendonitis, it could be either the long head or the short head. One feels for the area of maximal tenderness, and then one can inject underneath, such that making sure that the injection doesn't go into the tendon itself. Same thing with lateral epicondylitis, tennis elbow. One feels for the maximum site of tenderness, and the injection point of entry is through the muscle, and the idea being that the steroid spreads out underneath the muscle around the point where the tendon attaches, so that the enthesitis can be controlled. Aftercare, there's usually not too much aftercare involved. One band-aid over the injection site should suffice. Let the patient rest for a few minutes, if at all. There should be advice to not overuse or overexert for some time. Bed rest is usually not required, and of course, let you know if there are any problems. What potential problems can there be? If one follows this kind of a low-touch technique using sterile proper equipment, that's usually fairly safe. Discomfort is usually initially when the needle is going into the joint. After that, it tends to be rather painless. Sometimes post-injection, because of the steroid, one may feel a transient increase in joint pain, which can be usually taken care of by an anti-inflammatory or analgesics. Subcutaneous tracking of steroid can be a problem, because if it tracks underneath the skin, it can cause depigmentation and subcutaneous fat atrophy, which tends to be very distressing, particularly for ladies if it's around the hand. And this tends to happen more so with small joint injections or soft tissue injections, so one should be careful about that. The most important problem potential can be that it may not work, and I think in the initial counseling one should mention to the patient that there is a chance it may not work, but at least it won't make the matters any worse. Infection, if we follow the procedure outline, is fairly unlikely. So I'll stop here as the initial introduction. I'll first leave it open. Would any of the faculty, Bhupinder, Nikunj, Isha, want to add something? Want to add anything to this? Okay, so any questions? So far? No question? Yeah.
Is it, especially for knee joint, Is it also necessary to aspirate the joint first before putting in any injection, intra-articular?
Not absolutely essential, but aspirating it does two things. One, it tells you that you are actually in the right spot. Because if you get fluid, then you know you are in the joint. Because that's one of the other issues with this kind of a blind procedure, that you may not necessarily be in the area where you want to be. So with the knee, and that's a good point, that you can get fluid and you know that you're in the right spot. And the other is, if there's a reasonable size diffusion, initially it makes it very comfortable for the patient. So the patient feels better by the aspiration, and then by the time it's going to start to refill again, the steroid starts to work hopefully, and the patient, and that relief continues.
So you had marked 4 points over the knee joints. So we can inject in any of the 4 areas.
No, the idea of the marking, I mean, see, this is only something which I tend to do. Hang on, how do I do that? So the point I was trying to make was that this is where we want to inject. So if we mark here, then you've actually put an unsterile thing on the point where you want the needle to go in. So you mark it outside the point where you want to inject, but it still points out to that area where you want to go in. So when you clean it and you drape it with betadine, you're not touching it, and then you can enter. Now, some people, what they do is they use a nail and they'll make an indent in the skin where they want to go in, and then they clean over it. So that indent stays for a few seconds, enough for them to go in. It all depends on how one is used to doing it. There's no absolutely correct way to do it. As long as it's correct and you do it, and you achieve your purpose.
Sir, are ankle injections also done?
Yes, we are, I think Dr. Isha is going to,
Dr.
Bhupendra is going to first tell you about the procedure, and then we've got the management to do that. This was just as a general introduction to the process of joint injection.
Sir, local anesthetic, we can use mixed together with deformatal or not?
Sorry?
Sir, in local anesthetic like Galocan, with mixed together with deformatal or not? We can use?
Some people do it, yes. I mean, it's not that it's not to be done, but as I said, the ones who don't, I personally don't mix local anesthetic with it. And the logic behind that is that if you mix local anesthetic and inject it in the knee becomes relatively pain-free, at least for some time. And during that time, the tendency or the chance is that the patient may overuse the joint, because the inflammation won't settle immediately. It takes a few days for the steroid to start working. So if you just inject the steroid, in some ways the patient still has discomfort, doesn't overuse it, and hopefully you get a better response. But some people do it and they find, and the patient responds to that as well.
So the local anesthetics work for only 2 to 3 hours.
Exactly. Yeah, but even in that time, the patient could overuse the joint.
Point of injection has to be the point of maximum tenderness or the synovial cavity.
If you want to inject a joint, then the point of entry has to be at an area where you will enter the joint. And that's what they will explain to you more in detail when they take up individual joints to inject. For soft tissue, usually the point of entry is the point of maximal tenderness, because that's where the problem is, either the enthesitis or the bursitis or whatever. So then it will be there.
So how long can you wait for the next steroid injection to be given in the same joint?
Again, there's no fixed guideline to that. One generally doesn't inject the joint again before, say, 3 months, after which one may inject it. But the real issue is that if you're having to re-inject a joint, that means that the inflammatory process is not under control. So one would also then start thinking about modifying whatever other disease-modifying therapy the patient is on, and switching drugs or whatever, so that the need for recurrent injections is not there.
So local nerve blocks can be used along with simultaneous injection?
I've never done that, but with what kind of advantage would that give? I'm not aware.
So along with the reduction in pain, we are injecting steroid, we are as such targeting the inflammatory component. And can we inject a local nerve block around the knee joint so that to target the pain also?
I'm not aware of that having been done. I mean, what
Some of
nerve?
our physical medicine consultants and friends are doing it. They are injecting, blocking the nerves around the knee joint so that the pain is reduced, and subsequently they are also injecting steroids in the joint. So can that be an option?
Well, to be honest, I've never done that. To my mind, the one potential problem with that I see is that the idea is not to take away the pain. The idea is to control the inflammation. So by blocking the nerve, if we take away the pain, the inflammatory process still is there. The same issue may be that the patient overuses the joint and we run into more problems.
So actually that is done by the pain specialist.
Sorry?
Practice pain medicine.
Yeah.
They are the ones who give the nerve blocks for various aches and pains.
Yeah, see, that may be for chronic non-inflammatory pain. Yes, fair enough. There is a definite indication.
So during visco supplementation, which one's better? Putting in only the hyaluronic acid or the combination of steroid and hyaluronic acid?
Right. Again, that's a good question. Sometimes post hyaluronic acid injection, one can get a reactive synovitis. So the logic in putting the steroid initially is to prevent that. But that happens very infrequently. And again, what it does is if you add a steroid, you increase the volume a little more. So the whole process becomes a bit more difficult. So some don't put it in. I don't put it in, for example, but some certainly do. And it's not that it's not to be done. I think if there are no more questions regarding the basic procedure, we'll carry on. And I think some of the questions we may have regarding specific joints will get answered by the faculty. So I think Nikunj is next. Yeah. And you're going to be doing the shoulder and the elbow.
Good afternoon all. And first of all, I would like to thank Dr. Gupta sir for providing the opportunity. Today, I will be covering two joints, that is shoulder and elbow joints. Basic outline is I would like to highlight the indications. Most of the indications are already covered by the sir. So if any specific indication for particular joint, that would be covered. The most important part would be to identify the bony landmarks and then various approaches for particular joint injection. Any specific complication or aftercare is required that I will discuss. In shoulder girdle injection, we have three basic injections that are routinely performed in rheumatology clinic. The glenohumeral joint, that is the shoulder joint proper, the subacromial space, and acromioclavicular joint. The basic indication to inject a glenohumeral joints, adhesive capsulitis, inflammatory arthritis like rheumatoid arthritis, spondyloarthritis, and crystal arthritis, and osteoarthritis. So these are the basic indications to inject a glenohumeral joint. There are two approaches to glenohumeral joint injection: the posterior approach that I prefer personally, and the anterior approach. So first thing is to identify the bony landmark, and first thing is to identify the posterior border of acromion process. The later on to identify lateral border of acromion process, and then to identify posterolateral corner of acromion process. So the injection point is approximately 2 finger grip below and 2 finger grip medial to the posterolateral corner of acromion. So this is the injection site. The needle should be inserted from here, and it should be targeted to the coracoid process of the same joint. So we should process anteromedially, targeting toward the coracoid process. If one encounters bone, it is better to withdraw slight and readjust the direction so that we are in the joint cavity. So this shows basically the direction of the needle. So it enters from below the posterolateral corner and it is targeted toward the coracoid process. The second one, that is anterior approach, it is relatively easier and you are almost always sure that you are in the joint line. With posterior approach, around 70% you are in the synovial cavity, but around 30% injection are not within synovial cavity. So in anterior approach, we start with identification of coracoid process. The second one is to identify the medial border of humeral head that is easily located by internal and external rotation of the humerus, and we inject in between these two. So it is relatively a superficial and straightforward approach. One need to be cautious that we need to identify this bony landmark properly. If we go a little downward, there are neurovascular bundles like brachial plexus and axillary artery. So we should identify exactly the coracoid process and then to inject. The target point for anterior approach is the entry point of posterior approach. So we should target posteriorly and little laterally. So in anterior approach, needle goes beside coracoid process and it targets toward the posterior and medial. The aftercare is as usual as mentioned by sir. The second important structure that we inject is subacromial space injection. The basic indications are rotator cuff tendinitis or tendinopathy, rotator cuff impingement, subacromial bursitis and adhesive capsulitis. Here also the bony landmark are same as we identify in the posterior shoulder injection. So first is posterior border of acromion, then lateral border of acromion, and then posterior lateral corner. So injection site is same, it is 2 fingerprint below, but not medial, 2 fingerprint below the posterior lateral corner. And now the direction of needle is little different. We target acromioclavicular joint. So needle is directed anteriorly and superiorly. So it goes into the subacromial space. In adhesive capsulitis in older age people, this subacromial space communicate with shoulder joints. So subacromial space injection serves two purposes. It subsides the inflammation in subacromial bursa, and it will also take care of shoulder joint proper. The second approach, so needle will go like this. And second approach to subacromial space injection is lateral approach. The bony landmarks are same, but now the point of entry is the middle of the lateral border of acromion process. It is a rather difficult approach because the convexity of the humeral head interfere with the needle passage. So I personally prefer posterior approach. The acromioclavicular joint is injected in osteoarthritis and osteolysis of distal end of clavicle. It is a superficial joint, but it is difficult to locate in obese or muscular patients. One should start from medial end of clavicle and try to trace it toward laterally, and when one is in the joint, one will find a step-like gap between acromion and clavicular joint. And if one is not sure, overhead abduction or lateral abduction will help in identification of acromioclavicular joint line. The injection in acromioclavicular joint is difficult because there are tough structures around the joint. The ligaments are tough and joint space is limited, and there is partial meniscus inside the joint. So one might find some resistance while penetrating the joint capsule. The second region is elbow joint region, and in elbow joint region we inject elbow joint, olecranon bursa, and two epicondyles, medial and lateral epicondyles. For elbow joint injection, the common indications are the same, that is rheumatoid and other inflammatory arthritis and osteoarthritis. The common approach is from posterolateral side, because on medial side there is ulnar nerve, so one would not inject from medial side. The first thing is to draw a triangle. The triangle is drawn by lateral epicondyle, radial head, and lateral border of olecranon process, and one directly inject into the triangular soft tissue. The needle should be aimed toward the midpoint of cubital fossa. The second important structure that is injected is olecranon bursa. Common indications can be crystal arthritis, rheumatoid arthritis, but it is also a very well known site for septic arthritis. And before injecting, one would like to aspirate, and if it is cloudy, as I pointed out, then one should avoid injecting corticosteroids. There are two approaches to olecranon bursa injection and aspiration. One is to hit the maximum fluctuant point. The issue with this approach is it is easier, but one might encounter chronic post-procedure leakage of fluid. So second approach is to go from the healthy skin and then to hit the bursa. With this tunneling technique, one might avoid chronic post-procedure leakage of fluid. Here also one would like to use from lateral side rather than from the medial side, so as to avoid ulnar nerve. There are two epicondyles, the medial one commonly mentioned as golfer's elbow, and the lateral epicondyle commonly mentioned as tennis elbow. Here we use the same principle. We hit the maximum point of tenderness. The needle is inserted till it reaches the bone, and then slightly withdrawing and then injecting the steroid. The method is same for both medial and lateral epicondyle. Few precautions are required in these injections. One need not to avoid directly into the tendon. So if there is too much of resistance, better is to either withdraw little bit or to push little bit and then inject, because injection directly into the tendon might lead to tendon rupture. Few specific complications, as I mentioned, it is tendon rupture. The second important thing I would like to mention is skin depigmentation, because it is a superficial injection. If we inject too superficially, steroid might accumulate in the subcutaneous tissue and later on lead to skin depigmentation or fat atrophy. One should avoid injecting the longest acting, that is triamcinolone hexacetonide, while injecting superficial structures. And when one is injecting medial epicondyle, transient numbness in the ulnar distribution, that is hand and ring and little finger, might happen if somebody is mixing steroid with local anesthetics. So local anesthetic might pass into the posteriorly into the ulnar nerve, and then transient numbness might be there. Thank you. If any questions?
As well as the length, it is commonly used for the wrist, knee and the other joints. So for wrist we usually use 25 gauge and the length is 1.5 inches, and for knee it is usually 20 or 22 with 1.5 inches. Then this is an important slide. This is for the small joints which was not covered previously. So in hand we would also be doing PIPs, NCPs, carpal tunnel syndromes, trigger finger and the first CMC joints. So in case of PIP, NCPs as well as in trigger fingers, insulin syringe can also be used, since this is a very small space subcutaneously where we are going. And again the length of the needle is also very less. We can go with the half-inch needle for both PIP, NCPs as well as for the trigger finger. In carpal tunnel syndrome we still go deeper, so we need to have 1 inch length of the needle. The dose of steroid for the very small joints like PIP, NCP and first CMC is supposed to be very less, and even in trigger finger we hardly use 15 to 20 milligram of depometron. So first, a brief anatomy of the for the wrist joint. So only we need to know three things here. First, we need to know the radial styloid process. We need to know the ulnar styloid process and the Lister's tubercle. So Lister's tubercle is a very prominent bony landmark if we want to inject the wrist, which is the main joint of the wrist, the radiocarpal joint. So then we should be aware of the various extensor tendons of the wrist, of which we should be aware of the extensor pollicis longus tendons, the extensor indicis tendon, extensor digitorum and extensor digiti minimi. Because when we are going to inject a wrist joint, we have to avoid damage to any of the tendons which are coming on the way. And the last is the one which I have highlighted, that is the Lister tubercle, and we are going to go between two tendons, the tendons of the thumb and the tendon of the index finger. So that is the space we are going to inject for the wrist joint, which is the radiocarpal. So coming to the procedure, so this we have covered, 30 to 40 milligram of steroids we are using and 0.5 ml of 2% xalocaine. That is, some people use and some don't use, that is up to us. The position of the patient is very important. The arm has to be abducted and elbow has to be flexed and palm should be facing down. So the position of hand has to be like this. The approach is the dorsal approach. A towel is placed under the wrist. Ulnar deviation and slight palmar flexions open the joint space along the radial aspect. So that should be done. Then we clean the area. The first step is we palpate the Lister tubercle. So Lister tubercle is a bony prominence on the radial bone. Distal to the Lister tubercle, we locate the depression which is between the thumb and the index finger extensor. So between the two extensors, as visible in the picture, there is a depression between the two extensors. Needle is inserted perpendicular up to a depth of 2 cm. And then we aspirate and then inject. Usually in wrist joints, in most of the joints, usually we try to aspirate first and then inject so that we are not anywhere in any of the vessel. Now these two I have included in the slides, ulnocarpal and ulnar styloid. Usually, routinely I am not doing this because of the risk of damage to the tendon on the way. But in mannequin we can surely discuss about these two approaches. Then is the trigger finger and the trigger thumb. So there are specific locations for all the 4 digits, all the 5 digits for the trigger digits. For the index finger, the location is just distal to the proximal palmar crease. So it's just distal to the proximal palmar crease. For the long finger, that is the middle finger, it is between the proximal and the distal crease. For ring finger and the little finger, it is distal to the distal crease. Again, we will discuss in the mannequin all of this. And for thumb, it is just proximal to the digital crease, which is aimed at the sesamoids. The needle is inclined at 45 degrees. We palpate the tendons on finger movement. So palpation is very important. And as someone had asked previously, in trigger finger, in tendinitis, or when we are doing such kind of injections, the point of maximum tenderness is usually the point of entry. We also have to be very sure that we are not into the tendon. The area where the steroid has to go is between the A1 pulley and the tendon. So that is the space where he has to go. So when we will do this injection, first we insert the needle and then we ask the patient to do finger movements, flexion movements. If the needle is moving with the finger flexion, that means we are inside the tendon and we have to withdraw our needle and then we have to again see whether the needle is moving or not. So unless and until we are reached a point where needle is not moving, that is the point where we have to do the injections, and not when the point needle is also moving with the finger movements, which means we are in the tendons. For the carpal tunnel syndrome, the site is 10 mm proximal to the distal wrist crease. It is medial to the palmaris longus tendon. So in some people this might be absent. So in those cases we use the midline approach. So rather than palmaris longus, we will use the midline approach. The needle is inserted to the depth of 0.8 to 1 cm at 45 degree distal and lateral inclination. And it is injected into the proximal extension of the ulnar bursa as in the images. So the needle direction of needle is 45 degrees distal and lateral inclination. And we go up around 0.8 to 1 cm deep in the carpal tunnel syndrome. For PIPs and LCPs joints, as previously mentioned, in both of these joints, the amount of the volume of steroid which goes is very less, hardly 1 ml. So we will see a bogey swelling in a patient who has a MCP joint swelling or PIP joint swelling. The space is medial or lateral to the extensor tendon. So again, we have to be sure that we don't damage any tendon. The needle is inserted obliquely with the tip passing under the extensor tendon. So for both the MCPs as well as PIPs, the joint space is medial or lateral, so we have to go under the tendon. So for the second MCP joint, it is usually the radial approach which is followed. Now the first CMC joint. So in this joint, it is at the distal border of the anatomical snuff box, which has borders of EPL with EPVN extensor pollicis longus with extensor pollicis brevis and abductor pollicis longus on the other side. So the needle is inserted at the base of first MCP joint. Needle inserted is vertical to the skin surface. Again, a soft tissue, dequervent stenosynovitis. So we identify the tenderness located in the tendon sheath of abductor pollicis longus and extensor pollicis brevis. The injection is directed directly between these two tendons, and the needle is aimed towards the radial styloid which underlies the sheath. So the direction of needle is parallel to the tendon, and we aim towards the radial styloid process in this. In this injection, it is very important that we pull the needle back by around millimeter, and then the injection is attempted, so that we are in the sheath and not inside the tendon. Any which ways, if we are inside the tendon, we are going to have a strong resistance and will not be able to push the steroids further. Now coming to the knee joint. This is a detailed anatomy, but for knee joint it is very simple. We just need to know how to palpate the border of the patella bone. Because our knee injections, both medial as well as lateral as well as suprapatellar approach, we just need to know the patella. So these are the bursa around the knee, which are usually when the fluid is there, effusion is there, these bursa enlarges. So we should be aware of this. So there are three approaches: medial approach, lateral approach, and suprapatellar approach. Again, 40 to 80 milligram of MPSS, methylprednisolone, 1 ml of lidocaine we use. I usually use 20 dose needle for knee injection. With 10 to 20 ml of syringe for aspiration we should have, and 5 ml syringe for injection. In the same prick we have to aspirate and then we have to inject. So needle remains at that point and only we remove the syringe. Aspiration should be attempted before injection. So patient should be in the supine position, knee should be relaxed slightly and flexed. We palpate the lateral or the medial borders of the patella. So that depends on whether we are going medially or we are going laterally. So I started with lateral approach in my residency, and later on, now I am mostly doing medial approach for knee injection. So in both medial as well as lateral knee injection, there is just a slight difference. We have to identify the point at which the proximal 1/3 meets the distal 2/3 of the patella border for lateral approach, while for the medial approach it has to be midway between the two. The needle is inserted under the patella and in a slightly cranial position towards the suprapatellar bulge. So knee injection is, among all the joint injection, this is something which we do very commonly, and the joint space is big, so it is also easy to go inside the knee joint. Now lateral suprapatellar approach. This is considered as a safe approach, and we use it in very massive knee effusion when the bulging is very apparent. We mark two lines. One will be perpendicular to the upper border of the patella, and one will be perpendicular to the lateral border of the patella. At the point of intersection of the two lines, we insert our needle, and the needle is inserted towards the anterior surface of the distal femur. If there is a massive effusion, we are going to get fluid on slight aspiration. Infrapatellar approach. So this is a difficult approach. I am not doing it very regularly, and it is also less well accepted by the patients. Then we have prepatellar bursitis. In this, the point of maximum fluctuance is identified. We advance the needle into the center of the bursa in this. And then we have pes and serine bursitis, not something which I do commonly. So medial tendinous border of the thighs are first palpated and then followed. First knee in the semiflexion, the mark is placed, then knee is again extended and needle is inserted perpendicular until the contact with the tibia is there. We instill an area of 3 cm in diameter adjacent to the periosteum in this. Thank you. Any questions?
Good afternoon, everyone. Thank you, Ajit sir, for this opportunity. This would be the outline of my discussion. So first of all, foot anatomy. Foot is divided into three parts. The forefoot is made up of metatarsal and phalanges. The midfoot is made up of metatarsal bones, tarsal bones, 3 cuneiforms, 1 cuboid, and 1 navicular. And hindfoot is made up of talus and calcaneum. The joint between the tarsal bone and metatarsal bone is known as tarso-metatarsal joint. The joint between the hindfoot and midfoot is mid-tarsal joint, and joint between talus and calcaneum is subtalar joint. The ankle joint is between the lower end of the tibia and talus, that is tibio-talar joint, where the ankle plantar flexion and dorsiflexion takes place. But whereas the subtalar joint, where the predominantly supination and inversion and eversion takes place. We should be aware of few anatomical landmarks on the ankle joint. So the most important is this extensor hallucis longus tendon. We can identify easily by dorsiflexing our great toe. So this is the extensor hallucis longus tendon. Lateral to this is, why it is important? Because lateral to this is the neurovascular bundle. So we should avoid injury to neurovascular bundle. Medial to extensor hallucis longus tendon is the tibialis anterior tendon. So these landmarks we should aware. This is the exhausting list of differential diagnosis of foot and ankle pain. I am not going into the detail. The important point is we should be aware of where is the pain arising. What is the underlying structure from where the pain is arising, whether it is bone, whether it is joint, it is ligament or tendon. Next step, as a rheumatologist, we should identify whether it is mechanical or inflammatory in nature. So usually patient comes to us with ankle pain in rheumatoid arthritis, osteoarthritis or other inflammatory arthritis, great toe pain in gout or osteoarthritis, interdigital neuroma pain, plantar fasciitis and tarsal tunnel syndrome. So I would be explaining these sites of injections. So first is ankle joint, that is tibio-talar joint. Anteromedial approach is most common because it is easier to do, less painful, and there is less risk of injury to the neurovascular bundle. Ask the patient to lie supine, knee flexed at 90 degree, ankle slightly plantar flexed, for which we can apply a small round pillow below the sole. Important is identify the joint line, because being seen just on the surface anatomy, sometimes the ankle joint truly may be away from that what is seen on the surface. So always plantar flex and dorsiflex the ankle joint to identify the exact joint line. Then identify the extensor hallucis longus tendon by asking the patient to dorsiflex the great toe. Once you identify this, just go to medial, that is tibialis anterior tendon. So we have to inject just medial to the tibialis anterior tendon, posterior laterally tangent to the curve of talus. So this is our tibialis anterior tendon, this is talus and this is medial malleolus. So there is a small dip over here. Inject the needle perpendicular to the skin surface and posterior laterally up to 1.5 inch. So we are aiming this space. So this is our extensor hallucis longus tendon, this is tibialis anterior. So we are aiming this space posterior laterally. So go 1.5 inch deep. Just always try to aspirate. If it is in the fluid, as I said, it reaffirms that we are in the joint. If there is no pus, we can inject it slowly. The material, the cocktail is the same. The 2 ml of 80 milligram of methylprednisolone or triamcinolone plus minus 1 or 2 ml local anesthetics. The anteromedial I usually prefer. The other approaches is the anterior one and the lateral approach. In this approach, we can put the needle just between the tibialis anterior and extensor hallucis longus tendon. So this is also very easy. Procedure is same, perpendicular to the skin surface. Go slightly posterior laterally, 1.5 inch deep. This lateral approach I usually don't prefer because it is very painful and sometimes it is very difficult to identify the space. Although we can identify this dip area. Pointer काम करते हैं? Hello?
we can identify this dip, but it is sometimes difficult to do and it is more painful. The direction should be towards the medial malleolus. Here it is shown in this picture. So this is ankle. Subtalar joint, that is lateral approach is preferred because it is less painful and lesser risk of damage to neurovascular bundle, and it is easy to identify the sinus tarsi. This is basically a cylindrical small space between the talus and calcaneum. So the position, supine position, ankle in the slightly inversion position so that we can open up the sinus tarsi. The joint, always identify the joint line by asking the patient to do the movements, that is inversion and eversion at the subtalar joint, and it is the joint line is basically at the anterior and inferior to the lateral malleoli. Mark the side which is just inferior and slightly anterior to the tip of a lateral malleoli. Insert the needle perpendicular to the skin in the direction of posterior end of medial malleolus to approximately 1 inch. The important point is there is talocalcaneal ligament inside this subtalar joint, so it can produce resistance. So once we pass through this resistance, this gives us a pop-up feeling. It means that we are inside the joint. Always try to aspirate and then inject. So we are targeting this this space. This is sinus tarsi. So we can hold the ankle joint from behind and we can supinate and pronate the ankle, and we can identify this dip area. This is slightly inferior and slightly, this is inferior and slightly anterior to the lateral malleoli, and the injection direction should be posterior end of medial malleolus. Plantar fasciitis, very common we encounter. Ask the position is supine, hip in full, external rotation, knee slightly flexed, ankle neutral position, frog-like position. Stand yourself medial to the affected foot. Identify the point of maximum tenderness. So this maximum tenderness, it is the insertion of the plantar fascia aponeurosis at the medial tubercle of calcaneum. So draw one perpendicular line from the posterior border of medial malleolus like this, and draw one horizontal line 1 finger width above the sole, where these two lines are intersecting, and this is our injection site. We should be aware of this anatomy, as it is here it is the heel fat pad. So injury to this heel fat pad can lead to atrophy. So we should avoid this injection into the heel fat pad. We should aim toward this point, that is the insertion of the plantar fascia aponeurosis, and this we can get by intersecting these two intersecting lines, and this is the point of maximum tenderness as well. There is one approach, plantar approach, I didn't include because through the sole, that is very painful, and there is more risk of getting the heel fat pad atrophy. So I usually don't prefer that approach. This lateral approach is the medial approach for the plantar fascia is very easy to do. First MTP joint, very easy to do, perpendicular to the skin. We can inject. We can apply slight traction on the joint so that it can open up slightly. The second approach is we have identified the joint line. We can mark the insertion site slightly away from the joint line and inject it on an angle. So this approach is also very easy to do. I am not including the injection size and material as already been discussed by the other speakers. It's a small area, so we can inject only 10 milligram of triamcinolone or methylprednisolone. Morton's neuroma, this is the pain and paresthesia in this web area because of this digital nerve, thickening of the interdigital nerve. Injection is very easy. It is identify the two head of the metatarsal bones and half inch away from the web space, perpendicular, and half an inch deep we can inject. So I am just completing the theory part. We usually don't inject blindly because these are usually injected under ultrasound guidance. This tibialis posterior or peroneal tendon sheath injection. The first structure which traverses just below the medial malleolus is tibialis posterior tendon, and just below the lateral malleolus is the peroneal tendon. So if there is apparent swelling and tenderness is there in this area, so we can attempt the blind injection. So first we have to identify the pulsation of tibialis, this posterior tibial artery pulsation. Once we have marked this the artery pulsation, we can inject just posterior to the medial malleolus, an angle 45 degree of an angle to an arbitrary line joining the great toe to the heel, like this. But again, I am not using it blindly. Second, tarsal tunnel syndrome. Just like the carpal tunnel, there is compression of this tibial nerve in this area because of many causes, whether due to inflammatory or mechanical cause. We can inject it, but we have to identify first the posterior tibial artery pulsation, mark it just below the medial malleolus. The angle is 45 degree to the arbitrary line to the great toe to the heel, and inject it parallel to the skin just underneath the flexor retinoculum. Last is the injection of the peroneus brevis or longus tendon. This area is sometimes painful, and this is because of the inflammation at the insertion site of these two tendons at the tuberosity of fifth metatarsal bone. So if there is local tenderness is there, we can inject it proximal to the head of the metatarsal where the insertion lies. So injection is at a 30 degree of angle. Again, it's a small area, use very small amount of steroids, and smaller larger gauge needle, thin needle, and small size needle, maybe 1 inch or half inch needle. These are the references. Thank you. Other than knee joint, ankle is very easy to inject.
Is it popliteal bursa injection? No. Popliteal bursa? No. It is not. Popliteal bursa?
No, usually there is a connection between, usually don't inject simple.
Because I have not heard of
No, we inject directly to the
So no questions.
Landmark and where the needle is to be directed, the first entry into the skin is painful, and then usually not more uncomfortable after that. And then avoiding and putting in the local anesthetic tends to obliterate some of the landmarks that one can see. So it makes it slightly more difficult. Some do use it. I don't. Everything can't be that clear that there are no more questions. Must be some. Okay, now let's have a show of hands. How many do not do routine intra-articular or soft tissue injections amongst us here? So again, roughly about 50-50. For the ones who inject, no questions. I have just, yeah.
Have you seen a reaction with only depomedrol? Depomedrol knee injection, for example, and the knee swollen after that. I'm not talking about hyaluronic.
Yes, you can, and the kind of explanation is the crystal structure of the crystallized structure of the steroid. Sometimes that can irritate the joint. To be very honest, I have not seen it other than an odd situation where a patient might say that he or she has not achieved relief from the procedure. So now, whether it's the fact that they haven't responded, I have not really seen a very large increase in the inflammation post steroid injection, but it is described. It can happen. Then your main concern then is it an infection? Because if you've injected a joint and the patient comes back.
It should take time, no?
Sorry?
In a matter of a few hours, if it gets swollen and red, that should not happen in an infection.
That should not happen. I think that would be very unusual. Few hours I have not come across that.
So, hyaluronic is known to sometimes cause.
Yes, that can do it fairly rapidly. Yeah.
My boss had a patient who reacted to depomedrol like. So
Within a few hours?
Yes. So he's now started giving depomedrol test doses. Every it seems a little odd to give a steroid test dose.
Right.
But then, as you said, crystals can sometimes.
Yeah, but that would not be an allergic response. That would be a kind of a mechanical or an inflammatory response to the steroid, which usually takes a day or two at least to materialize. I'm not aware of within a few hours. That would be very unusual. But then unusual things can happen, and we've seen, and it has happened to a patient. So, but I can't
So,
explain
in
it.
case of a red swollen joint after any joint injection, maybe hyaluronic, what should be the management plan?
See, I think particularly as far as the knee is concerned, I make it a point, and some do stress that if we aspirate fluid, we test it regardless of whether we clinically suspect infection or not. Because that achieves one very important thing, that it actually tells you that when you made the injection, the joint was not infected. Because if you do a cell count and a gram stain, as a minimum, I don't think we need to do anything much more. If the cell count is not in a kind of alarmingly high range and the gram stain is negative, you can be reasonably sure that there is no infection. Now, the other way one might explain a sudden increase would be if the joint was already infected and we injected it. That might be so. But then if we've not examined the fluid before the injection, we may not know the answer. And to answer your question as to what to do, at that point in time, one could perhaps for some time treat conservatively with maybe ice packs or anti-inflammatories. If it persists, then we aspirate the joint to check for possible infection.
So, you aspirate every time you inject the knee joint, that's the dictum, right?
Yes, as a rule of thumb, yes, try and aspirate the fluid and check it each time.
So you get some fluid which is clear looking, it does not look infected, and you put in the steroid, and then you send that fluid for examination, and that comes back as infected.
Then you're in trouble.
Yeah.
See, initially the patient will improve even with the steroid, even if it was infected. Then you go back in and re-aspirate and start and confirm it, and then start the patient on appropriate
But then
antibiotics.
you've probably thrown yourself into legal trouble yourself.
Well, I think if one explains to the patient, one can avoid legal trouble. If you explain to the patient that, look, there is a slight chance that there will be, one could cause an infection, which is very, very rare, which is true, that's the correct thing. But yes, I mean, that is one potential problem. But to be very honest, I haven't seen that in now almost 40 odd years. I've not seen that a joint which was not infected, one has actually infected by an injection done with the proper, sterile guidelines. Now, it may be the patient didn't come back to me.
No, I'm not talking about the post-injection infection. So you said that you withdraw fluid and you regularly test it. But if you get clear fluid, you will anyway inject the steroid, right, with the patient in the same sitting. And now, do you send that fluid for examination routinely?
Yes.
So that after 2 days or maybe the next day it comes back as infected. Now
So what it means is that the joint was already infected when you...
And you've injected steroid in it.
Right, yes.
Now you just watch.
So then you call the patient back and then you re-aspirate and treat and hope the patient doesn't sue you.
So, I mean, is it, okay, so thinking from the perspective of protecting doctors, do you send every fluid for examination or not?
From the knee?
Yes.
Yes,
If
I
you
do.
get some fluid which is absolutely clear.
I do, yes. Having said that, there are always exceptions. I mean, there is no absolute. Sometimes at the end of a very busy clinic or there's no time, the patient says, "No, doctor, I can't take it to the lab. It's absolutely clear and I may not have sent it." But by and large, I tell the patient beforehand that if we get fluid, we're going to check it. Are you going to be able to take it to the lab, or if it's in the hospital, then obviously we'll send it. So yes, I mean 99.9%, I would do that.
Digometrol versus Iracon, which one do you prefer?
I personally don't think it makes any difference. Kenacort or triamcinolone the preferred preparation is actually triamcinolone hexacetonide. Now for many years over here we only got the acetonide. Now I believe hexacetonide has also become available or will soon become available. But even in a situation where both are available, they tend to work fairly equivalently, and it's a matter of one's own training or preference as to what you grow up getting used to. So I personally use methylprednisolone, but triamcinolone is equally. Recently, I think in recent times, there has been a problem with depomedrol becoming available. So I was using Tricort or Kenacort, and it works as well as the other.
So there is some studies saying triamcinolone has a longer action as compared to depomedrol.
Possibly with the hexacetonide. Yes, some prefer it, but in situations where, like say in the UK, where both were available and both were readily available, and one would use them interchangeably, one didn't really notice. This is an arbitrary kind of answer, not a scientific study, but one didn't really notice a significant difference between the two in terms of response.
Is there any increased risk of degeneration of the joint? And if there is, which is the steroid that causes more?
See, if one injects a joint which is not inflamed repeatedly, then I suppose yes, there would be a risk of causing cartilage degeneration. But if we look at it this way, that we are injecting an inflamed joint, we are actually protecting the joint by reducing inflammation, even if though it may be for a short period of time. But then if we repeatedly inject an inflamed joint, then we have to ask the question that, some systemic treatment needs to be instituted or modified to control the inflammation. The local injection can only be a temporary measure as a stopgap.
Sir, any role of giving injection adalimumab or methotrexate intraarticular? There are
Giving an anti-TNF in the joint?
There are papers.
There are some studies, yes. Even for osteoarthritis, they have been mentioned, and even for inflammatory joint disease. But I think with inflammatory joint disease, our management has improved so much in recent times that probably intra-articular there may not be much role in that. So shall we move to the mannequins? Okay. So I think there are 5 tables. So if you divide yourself, roughly how many are we over here? 30? So if you divide yourselves maybe 6, 7 to each table, and then every 15 minutes if we rotate, we should be able to finish all of them towards the end.
These is at 90 degrees flexion. It's like